Thank you very much. So let me give you a little bit of background about Cambodia. For those of you who do not know where Cambodia is, we are located in the Southeast Asia, bordering with Thailand, Vietnam, and Laos. It is a very small country with a population of only over 14 million people. Cambodia made significant progress in reducing the child mortality in the last 15 years. However, the progress in child nutrition has been stagnated in the last 15 years. For example, 40% of Cambodian children are stunted, affecting country, economic education as well as productivity for the next generations. Over 70% of Cambodian children are infected with the intestinal worm, especially hookworms, ranking from 22 to 82% among the school we conducted the surveys in the past. And we all know that the chronic and intense STA infections are strongly linked to the poor nutrition, especially anemia, and this could lead to overall poor school performance. Could you please go to the next slide? Please. Thank you. With that problem, Helen Keller International, in collaboration with the Cambodian Ministry of Education and other stakeholders, implement a curriculum development project to try to address the problem of STH. Uh, for that, I would like to highlight the key implementation step of this project. The first, after several discussion and meeting with the Ministry of Education, we then signed a memorandum of understanding with the ministry outlining the role, responsibility, key activities, and time frame of the project implementations. We then conducted the stakeholder analysis to assess what is being done, where, how, and by whom with regard to the school health activity with a focus to the STH prevention and control. One of significant finding from this situation analysis was that the government curriculum at the primary school level allocate only 2 hours and a half per year to discuss about the STH topics. So that is really a big gaps on the STA discussion at the primary school. After that situation analysis, we conducted a planning workshop to share that finding, and following that workshop, the technical committee and advisory committee were established to oversee the curriculum development. And the committee on the technical aspect is focused on drafting the curriculum, while the advisory committee is responsible to overview and editing the curriculum. So then we start the curriculum development process by the committee, and it took us for 7 months to get the first draft of curriculum. Then we start the training of the master trainer at the national level on how to use the curriculum, and following the training of school teacher on this draft curriculum. Then having done to pilot this, the use of the curriculum in 4 primary schools in Cambodia. Following this pilot, it took about 3 months. Then we conducted assessment on the use of that curriculum in the pilot school. Then we gather the feedback, from the teacher and student as well as from other stakeholder to finalize the curriculum. Eventually, the curriculum was approved by Ministry of Education. Could you please go to next slide? Now, what are the main success from these projects? We have been working with a wide range of stakeholders, including, 6 government departments. That include the school health department, rural healthcare department, national curriculum development department, and primary school department, as well as national malaria center. So that was a really a good collaboration and work with the stakeholder. And of course, another big success is that this curriculum was finally approved by Ministry of Education, and they announced that this curriculum should be used throughout the Cambodia for the primary school students' educations. Then we found from our impact assessment that the student and the school, the student and the school teacher who've been trained on the use of curriculum been increased in the knowledge on STA prevention and control. So that's really great. And then with the last 4-year support from Johnson and Johnson, we have reached to more than 100,000 students and more than 4,000 school teachers. Also, other NGOs have used this model and reached 150,000 students and more than 5,000 school teachers. So that is really a great success. And we look to the potential to further scale up through different stakeholders and actors. For example, those who engage in WASH and education, potentially they could use our tool and curriculum to expand this activity to reach more beneficiary students and schools. Please, next slide. Thank you. We encounter a number of challenges in the last 4 years, especially during the curriculum development projects, and that includes, consensus building among stakeholders at the curriculum development stage, especially on the content. Then you have 6 departments from different government ministry, and then the NGO sector, so they have a big debate, and somehow, it took some time to get agreement to the specific point of content and technical message. But that is normal, when you work with many stakeholders, that is not unexpected. Though the government have very strong endorsement, and place important priority on this curriculum, they have limited resource, to use for the scaling up of this curriculum. We also learned that the poor water supply and sanitation coverage at the school level undermine the behavior change effort. So some schools said that availability of a sanitation facility is also important in addition to the increased knowledge. So that is one issue. And in general, it is difficult for HAI and other actors to find the funding to scale up this program, So we depend again on the government for the future sustainability and scaling up in terms of resource and the capacity. Would you please go to next slide? In terms of what we can learn from these projects, to replicate in other health sector, we think that the evidence-based approach in terms of, getting through the design and pilot and scaling up, it is that is the best way, when you do any such a program, you need to consider that evidence-based approach, because it will give you the right directions, also, the right strategy to do the intervention and to fit the need of the country where you are working. Uh, that is very important. And the partnership also important, but more importantly, how to ensure the appropriate resource for the evidence-based approach. That is important because you want to prove it work, but then you need to have appropriate resource to be able to generate that evidence. Thirdly, publication and dissemination advocacy are really, really important, and to disseminate the best practices and findings from the program evaluation and the project we are doing. And there should be multiple channel to disseminate the research finding, through conference, workshop, and something like what you are doing there. So that would be good. And for us, we at the national level, we want to get attention to the policy maker, because from the government side, we want them to get ownership of these projects, and then they have the capacity required for the scaling up and the sustainability of the program. Please, next slide.
Hou, just so you know, you have around 2 minutes.
Yes, 2 more points and finish. That's the last slide here. So in terms what would be, the idea for the post-2015, this is just our idea. We think that global partnership is really important. So, the collaboration between government, UN agency, NGO, private sector, and community, very essential. For example, the current MDG funded projects implemented in Cambodia is only implemented by the government and UN. And we see that is not a good idea. It should be also, private sector and NGO involvement as well. And then, for the next post 2015, we think also the focus should be on sustainable development to address key global challenges ranging from malnutrition, food security, population, rural and economic inequity, instability of food price, etc. Thank you very much. This is all about my presentation. And once again, thank you very much.
Hou, thank you so much.